Hello my dear curious and studious students of surgery. Myself Dr. Mahesh Chaudhary. I am warm welcoming you in my surgery lecture series. This surgery lecture series contains entire surgery with anesthesia, with radiology, with orthopedic. So stay tuned with us. Let's start our surgery lecture series. Welcome dear students in my surgery lecture number 85, that is the tetanus. In this lecture we will cover the tetanus, bacteriology, pathology, clinical features, investigations and treatment. Tetanus. It is a condition of toxemia due to the absorption of soluble toxins from the wound contaminated with clostridium tetani. Bacteriology. Clostridium tetani is the causative organism which is a gram-positive anaerobic rod with terminal round spores, about 3 to 4 times wider than the bacillary body, giving rise to a typical drumstick appearance. It is mainly found in manure or soil. It is normal inhabitant of the intestine of human beings and animals. A low oxygen tension in the wound is necessary of Clostridium tetani is to grow. The exotoxin produced by a Clostridium tetani which causes tetanus consists of two components, that is the tetanospasmin and second is the tetanolysin. Tetanospasmin, which is the neurotoxins and acts on the motor end plates, and the tetanolysin is an oxygen labile haemolytic toxins. Now the incubation period, it varies from 3 days to 3 weeks, but on average it is 7 days. This period is increased in immunized persons. The incubation period is important as it indicates the severity of the disease. The longer is the incubation period, the milder is the attack. Mode of the entry, usually a penetrating wound due to the rusty nail, splinter or thorn in the portal of entry. In 50% of the cases, the wound is slight and healed before evidence of tetanus develops. Next is the dirty abrasion may sometimes lead to this condition, street injury, which is contaminated with the dust or excreta of the cows or horses, many causes tetanus. Third is the chronic ulcers of the leg, boils, parenchyma and dental extraction have also been implemented as a modes of the entry. And next is the tetanus may follow a subcutaneous injections of an irritant drug like quinine and emetine. It is also currently seen in developed countries as a complication of narcotic addiction, which has been called as the urban tetanus. Tetanus neonatorum results from contamination of the cut surfaces of the umbilical cord. It is an important cause of the infant mortality in developing countries. Soon the child ceases to cry and suck, followed by fever and convulsions. Severe spasm of the respiratory muscles is the common cause of death. Next is the post-abortal tetanus, that is the puerperal tetanus, results from unsterile manipulation or instrumentation during the abortion of labor. Next is the post-operative tetanus, sometimes follows elective surgical procedure, which is often due negligent breakdown in sterile techniques or caused by the contamination from the patient intestinal tract. Sometimes the wounds are so trivial for that they are oftenly forgotten. After months of years, due to some unknown changes which produces the right condition for Clostridium tetani to multiply and produce toxins and tetanus develop, this is known as the latent tetanus. Now the pathology. Manifestations of the disease are due to the absorption of soluble endotoxins from the site of infection. Implantation of the tetanus spores into the wound should be followed by an anaerobic condition in which these spores can germinate and the organism can multiply due to the low oxygen potentials of such tissues. From the site of the infection, the toxins liberated by the tetanus bacilli is absorbed and reaches the central nervous system. How does these toxins reach the central nervous system is a question. Various theories have been put forward. The toxin travels through the motor nerves along their axis cylinders to reach the core. The next theory is the toxin travels through bloodstream. This explains why the earlier effects, that is the trismus or difficulty in deglutition or rigidity of neck muscles or spasm of the muscles of the face, are well away from the wound. The toxin travels through the lymphatic along the nerve trunks of the central nervous system. Whatever may be the root or the theory, the exotoxins ultimately reaches the cord and is fixed to the motor cells of the anterior horn. Once it is fixed to the motor cells of the anterior horn, it cannot be detected in the CSF and no amount of ATS can neutralize these fixed exotoxins. With fixation of the exotoxins to the anterior horn cells, it causes extreme hyperexcitability of motor neurons in the anterior horn cells. This evokes widespread reflex spasm of the muscles. Moreover, the exotoxins produced at the inoculation site inhibit the cholinesterase at the motor end plates. This results is an excess of the acetylcholine at the motor end plates, which causes tonic muscle spasm. Now the clinical features of the tetanus, that the trismus is the most common early symptoms. It is often combined with the pain and stiffness of the neck, back and the abdomen. Occasionally, dysphagia difficult of deglutition appears first. These symptoms increase accordingly to the severity of the attack. Gradually, the patient shows the characteristically anxious expressions, rhesus sardonicus, in which the eyebrows and the corners of the mouth are drawn up. This is due to the spasm of the muscles of the face and jaws. The muscles of the neck and trunk gradually becomes rigid to varying degrees, and the back is slightly arched, a condition known as the opisthotonus. This rigidity is due to the spasm of the corresponding muscles, which are chronic as well as the tonic, and the relaxation is incomplete during the interspasmodic intervals. Psoas and the abdominal muscles may rupture. Next, every muscle in the body is gradually thrown into the intense chronic contraction. The jaws are tightly clenched, the head is retracted, the back is arched, and the limbs are easily extended. The constitutional symptoms are also seen, that is, the temperature becomes elevated, the pulse becomes rapid, and the patient may become cyanotic due to the respiratory failure, which is obviously an ominous sign. Now, the special types of the tetanus are, after describing the common clinical manifestations of tetanus, I would now like to mention a few special types of the tetanus, that is the acute tetanus, chronic tetanus, delayed tetanus, that is the latent tetanus, local tetanus, cephalic tetanus, bulbar tetanus, late tetanus, tetanus neonatorum, and recurrent tetanus. First, acute tetanus. In this type, the incubation period is less than 10 days and the prognosis is grave. Chronic tetanus. In this type of the tetanus, the incubation period is about 1 month. The clinical manifestations are less severe. These cases have been received prophylactic injections of antitoxins. Third is the delayed tetanus and or the latent tetanus. In this condition, the organism remains latent in the wound for months or years. Due to certain unknown change, the organism suddenly find right conditions to multiply and produce toxins. And fourth is the local tetanus. In this condition, there are local contractures of the muscles in the neighborhood of the wound. Often these cases had taken antitoxins and or probably endotoxins involves only the segmental anterior horn cells of the cord. Now the fifth type is the cephalic tetanus. In this condition, there is the irritation or paralysis of the cranial nerves which dominate the picture. The facial nerve is affected most often. Involvement of the ocular nerve causes ophthalmoplegia. Involvement of the hypoglossal nerves causes spasm or paralysis of the tongue. Trismus or dysphagia may also be present. In this condition may be the type of the local tetanus when it follows the wound of head and face. Sixth is the bulbar tetanus. In this condition, there is the extensive spasm of the muscles of the deglutition or respiration. This form is often dangerous as death is caused by the spasm of muscles of respiration. Late tetanus. In this condition, the inoculation period is considerably prolonged. Tetanus neonatorum, this has been discussed as earlier. Recurrent tetanus, the patient who has survived tetanus is not immune unless immunized. He may receive a second attack which is known as the recurrent tetanus. Now the treatment, first is the prophylaxis and second is the treatment of established cases. First in the prophylaxis, the active immunization. The best way to avoid the tetanus is to provide the active immunization to all individuals. This is done either by the formal toxide or alum precipitate toxide, that is the APT. Nowadays, aluminum phosphate absorbed tetanus toxide is used. Active immunization should be given to all children along with the toxide of diphtheria and pertussis vaccines, that is the DTP, which is culminately called the triple antigen. For active immunization above 6 years of age, 0.5 ml tetanus toxide is injected intramuscularly. For injection, left deltoid region is probably the best, followed by the gluteal region. The same dose is repeated after 4 to 6 weeks, and again the same dose is repeated after 6 to 12 months. Only after this third injection, the basic series is considered complete, following which is the booster dose of the same amount is injected every 4 years following the initial dose of the tetanus toxoid. Non-immunized individual requires approximately 30 days to acquire a safe antibody level. Now the second is the passive immunization. Equine ATS prepared for the horse serum may be given to the non-immunized individuals at the time of injury so as to give an adequate covering during the period needed to establish active immunity by the toxoid. The dose is usually 1500 international unit is used subcutaneously or intramuscularly. The disadvantage of these ATS are that a preliminary skin test is always required before administration to avoid the anaphylactic reaction. If the skin is test is positive, ATS should not be given. The effect of the ATS is obtained after 48 hours and the effect remains up to 2 weeks. And the second is human antiglobulin, that is the hemotate ATG is better than the previous ATS as it is the homologous antitoxin. Its protective values is 100 times more than that of the ATS and no skin test is required as being a homologous antitoxin. Similarly, chance of the anaphylactic reaction are nil. It may be given intramuscularly or intravenously in the dose of the 250 to 500 units along with the tetanus toxins. Achieve immediate immunization of gives adequate cover to the patient before active immunization provides adequate antibody level in the serum. And the third is the proper debridement of the wound. This is the prophylaxis treatment. If all lacerated and contaminated wounds are properly debrided along with the removal of the all dead tissues, the blood clots and the foreign bodies, chance of the tetanus will be almost nil. And the fourth is the antibiotic. Penicillin is the bacteriostatic agent for clostridium tetani and prevents the production of the exotoxins. Now, the second part of the treatment in the tetanus is the treatment of the established cases. First is the passive immunization, second is the antibiotic, third is wound care. In the passive immunization with 4000 units, the hemotate should be administered along with the tetanus toxin injection. If hemotate is not available, 1 lakh unit of ATS is given half intravenously and half intramuscularly. Antibiotics, high doses of the injection penicillin 10 lakhs units every 4 hours should be administered as the penicillin is the bacteriostatic agent for Clostridium tetani. It can be supplemented with the metronidazole to protect the lungs against the respiratory infection. If the patient is allergic to penicillin, tetracycline may be used. Third is the wound care. Surgical care of the wound should be immediate. The most important features of the surgical care are through cleansing and debridement. All necrotic tissues and foreign bodies should be removed so that the Clostridium tetani cannot get chance for further growth and exotoxin production. Fourth is the patient is isolated to a quiet, dark but well ventilated room. No external stimuli should be there to provoke the painful spasm. Fifth is the further treatment depends upon the severity of the cases. As in the mild cases, whether there is only tonic rigidity without any dysphagia or reflex spasm, the patient should be sedated with promazine 200 mg IM and the barbiturates, that is the amylobarbitone or injection diazepam 0.5 to 40 mg IV. These drugs are usually required to be repeated 4 times in 24 hours period. In moderately severe cases with dysphagia and reflex spasm but without any cyanotic convulsions, a nasogastric tube has to be passed for feeding. A self-retaining catheter is passed to drain the bladder. Intravenous fluid should be started and intake and output chart should be maintained along with monitoring of renal function. The patient must be sedated as mentioned above and tracheostomy should be considered. If the patient has difficulty in breathing, suction through tracheostomy tube should be done now and then along with the humidification. In very severe cases who are having cyanotic convulsions and more care should be taken to the maintain respiration, a muscle relaxant should be given in the dose of the 40 mg tubocurarine IV initially and subsequent injection by IM following tracheostomy which is performed gently under the local anesthesia. Positive pressure respiration should be started. Sedation with the pentothal sodium is necessary, which is the anesthetic drug. Nasogastric feeding should be started. Elimination of the visceral stimuli such as the distension of the urinary bladder is avoided by continuous catheterization. Intravenous fluid and electrolytes with a good monitoring of input and output is necessary. Constant nursing care is highly important in such cases. In the severe cases of the tetanus, when the convulsions do not occur after the relaxant have been stopped, usually after 14 days or so, the ventilator can be stopped. Now, the cause of the death in the tetanus, that the tetanus is a lethal condition and death is generally due to the respiratory arrest. First is the lung complication. These are the common causes of death. Pulmonary infection, mainly bronchopneumonia, aspiration of the pharyngeal content into the lungs, vigorous spasm of the respiratory muscles with laryngeal spasm causes airway obstruction resulting in cyanotic convulsions. Pulmonary embolism due to the dislodgement of the emboli from the stagnant limbs due to the excessive sedation. And the second cause of death is the death may occur from the drug intoxication, particularly the barbiturates, anemia and exhaustion, which may be so severe due to the repeated convulsions that the patient passes into the coma and expires. Hyperpyrexia and effects of the exotoxins on the brain may cause death. And the fifth cause of death is the previously anaerobic reaction due to use of the equine and or bovine tetanus antitoxins lead to death. But this cause has been eliminated with skin test and more use of hematite. The sixth cause of death in the tetanus is the compression of the fracture of the vertebra, especially the thoracic vertebrae, is more of a complication rather than cause of death. And the seventh is the complication from the coexistence disease may cause death and perforation of the peptic ulcers, rupture of the heart through the site of the infection, etc. due to the convulsions. Now the results. With modern treatment as mentioned above, the death rate has been considerably reduced to 15% in general for all ages, though mortality rate is still high in case of children and old age. Dear students, here is the picture of the patient in severe case of the tetanus. With this, here is the end of our surgery lecture number 85, that is the tetanus. Thank you.